you all so much for being here, and especially thank you to the COBRE on Opioids and Overdose, the Family Task Force, and Representative Slater for hosting this event. My name is Anna Jane Yolkin. I am a co-chair of the Substance Use Policy, Education, and Recovery PAC. The Super PAC is a nonpartisan organization that advocates for evidence-based policies to support Rhode Islanders living with substance use disorder and those in recovery. So we're really excited to have Dr. Goulão here all the way from Portugal to share some of their lessons learned over the past 2 decades of drug policy reform. I myself had the privilege of going to Portugal to see their policies in action, and it was really incredible. And to bring their successes into Rhode Island perspective, I wanted to focus on one data point. So in 2018, there were 314 people in Rhode Island who died of a drug overdose. If we had had the same overdose death rate as Portugal that year, only 4 people would have died. So we're really grateful that Dr. Goulão is here to talk about what lessons we can bring back to Rhode Island to save the lives of our friends and our neighbors, and specifically what types of policies we can apply here as well. One policy that we are working on here in Rhode Island is to reclassify drug possession charges from a felony to a misdemeanor. Other states that have done this, including our neighbors in Connecticut, have seen really great successes in terms of supporting people in their recovery. And so thank you so much, and I'm going to pass it off to Representative Slater.
Thank you, Anna Jane, and good afternoon. Thank you, everyone, for being here today. It's an honor and a privilege for me to host Dr. Goulão to be here today with us to talk about the work that he's done in Portugal and around drug policy. It's an honor, and I'd like to thank Anna Jane for putting this together and the folks that she works with. Thank you for all the hard work you've done on drug policy, not only here, but throughout other states, and in the state of Rhode Island. So last year, I had the honor of sponsoring the bill to reclassify possession and have it from a felony to a 2-year misdemeanor. And we're going to continue to work on that legislation this year to hopefully save some lives, really. But I'm not going to eat into Dr. Goulão's time, because he's the main attraction here today. But I look forward to introducing you on the House floor this afternoon and working with you on many of the policies. So with no further ado, Dr. Goulão, if you come up.
Thank you very much. Thank you for having me here. It's really a privilege. And I want to thank to all those, starting from Dr. Rich, that was the first one that I knew from Rhode Island. We met last year in a conference in Baltimore. And since the beginning they said, you must come to my town and speak to my people and share this history. So I want to thank to all those who made this tour possible. I see so many familiar faces, so some of you already listened to me in other occasions during this week. I hope not to bother you by repeating the story, but I want to take this occasion, first of all, to say that what I feel here in Rhode Island, and particularly here in Providence, is that you have all the tools available to give the step towards considering, and for me this is crucial, this is the basis for our policies, thinking about drug addiction as a disease instead of a crime. And that makes all the difference. Of course, people may talk about the differences of the health systems that we have available. In my country, for instance, we have a universal health service available for everybody. That's not the case in your reality, but you are giving the necessary steps to make care available for those in need for it. So it's not an excuse not to give this step. And I believe that you have the conditions to do so. And it really makes all the difference. It comes from the social representation of drug addiction, and it influences the social representation of drug addiction. What do I mean for this? Traditionally, drug addiction problems stood mainly among minorities, among in the ghettos, everywhere, not only here, all over the world, in other countries. But nowadays, the epidemic that you are facing here in the States with the opioids is attaining all social groups. It's no longer something that happens to the others. It's something that happens in your families, in every family. And this is a momentum to think, okay, why should I consider my son, my nephew, as a criminal? He's a sick person in need of help. And this makes all the difference. The practical terms to do so may vary a lot. In my country, we did it one way. I would like to share, but I think we do not have too much time to go in depth in that explanation. But in practice, what happens? Using drugs is still prohibited in my country. It's not liberalized or approved by society. No, on the contrary, there's a strong sign of social disapproval for drug use. But when people fall in addiction, like a disease, chronic relapsing disease, people are considered as sick person, and they must access treatment with the same dignity as people who suffer from other diseases. Some other diseases are a result of our behavior. Some sorts of diabetes, for instance, depend from what we eat. But nobody even thinks about putting a diabetic in prison because he eats too much sugar. Okay? Why put someone? We may consider this is a self-inflicted disease. Okay, you are addicted because you wished so. No, I'm not diabetic because I wish to be diabetic. I am probably weak. There are something in my genes, something in my that drives me to abuse sugar or sweets. Okay. If I smoke cigarettes and I get lung cancer, nobody puts me in jail. I'll be offered treatment, I'll be treated with dignity, even if it comes from my wrong behavior. Why put people who use drugs in jail? In my country, we have found a way when we were facing an epidemic with the same dimensions that we are facing now with opioids. In the 80s, 90s, we were facing an epidemic on heroin. And what we did about it, it was attaining 1% of our population, 100,000 people hooked on heroin. As it happens here now, it was attaining every family. It was impossible to find a Portuguese family that had no problems related to it. And how did we respond? By building a network of health services addressed to that problem. And then decriminalizing. Okay? We established, the way we did it is we established a limit for the possession of drugs. We have a drugs law that comes from '93. It is quite a tough law, inspired in the war on drugs. Okay? And in 2000, we just changed one article of that law. The article that deals with personal use and possession for use. And in that case, we established a limit for possession of drugs. And that limit is calculated on the basis of personal use for 10 days. If someone is intercepted by the police in possession of drugs, he is still taken to the police station, the drug is apprehended, is weighted, and if he has more than that amount, he is sent for the criminal justice system as before, up to the trial, up to the judge, up to the lawyers, to discuss and to decide if he is dealing drugs or not. If he is actually dealing drugs, he may end up in prison as before. But if the citizen has less than that amount, he is just sent, is just intimated by the police to present himself before a panel under the Ministry of Health, which is composed of a psychologist, a social worker, and a lawyer, and that are going to assess, to discuss with the person what kind of drug use does he have, and what kind of needs does he have. Are you someone addicted in need of treatment? Okay, we can manage, we can arrange a treatment easily accessible. Tomorrow you can start if you want. Okay? If there is someone who is not addicted, is someone playing with drugs, someone using drugs for recreational purposes, even then the panel tries to assess what kind of needs does this person have, what kind of use, what kind of conditions, how is his family, how is his work, where does he or she move, and what kind of difficulties is he or she facing in his life. How can we help to deal with those difficulties in order to avoid that the existing use of drugs along with those problems can lead him or her to a more problematic use later on. So the goal is to interrupt that career that can lead to a more problematic use. And I may ensure that this is effective, much more than putting people in jail for 2, 3, 10, 20 years. People can be sent back to society, people can be integrated, reintegrated in society much more efficiently than through the criminal system, through prisons, through all those difficult stages in life. So this is the main message that I would like to share with you. From then on, from that decision that was taken in 2000, since then in 2001 we had the complete set of a strategy put together. We have had an evolution in our data that is really impressive. Nowadays we have the lowest rates of overdose deaths in Europe. We had 38 deaths in 2017 all over the year, all over the country, a country of 10 million inhabitants. If you have the same rate, as it was said, if you had the same rate of overdose deaths by comparison with the population, you should have 3 or 4 a year. You are having 300. This is key, and this is easy. This is easy to do. I must say that, for instance, in the beginning we had some resistance from law enforcement departments. We are going to lose efficiency in dealing with drugs. 20 years later, they are the happiest guys in the world. And why? Because they got rid of all the tasks that seem to be completely unuseful, of dealing with the drug users on the street, arresting them, introducing difficulties in their lives, and in terms of effective combat to the traffic activities, it was not really efficient. As they got rid of all those tasks concerned to mere users on the street, they could address big, really big criminal organizations that perform bulk trafficking. And nowadays, by the end of the year, when they show their results, instead of showing grams or kilos that they seized on the street, they show tons that they apprehended in big shipments, in containers, in open sea. So it's a completely different way to work, but much more efficient, when the goal is to lower the availability of drugs on the street. So nowadays, when we adopted this law, at a political level it was difficult. It was not easy. The common citizen was very much in favor. As I said, everybody has had someone in their families attained by the problem. But at the political level, since by ideological points of view, it was much more complicated. Left-wing parties supported the idea, right-wing conservatives were opposed. Nowadays, there's a complete consensus in our society. Nobody even thinks about going back, because the results speak by themselves. And that's the case with overdoses, that's the case with the efficiency of law enforcement in combating the traffic, that's the case with HIV infections, that's the case with stigma, that's the case with the total number of addicted people, of problematic drug users. We started from 100,000 people using heroin. Nowadays we have less than 50,000 people depending on any drug, and from those, 30,000 are following treatment programs. So it's a completely different situation. Sure, we did not solve all our drugs problems. Every day we have new challenges. We are prepared to face the challenge of fentanyl that we still do not have it in Europe in the same proportion that we are facing here. And we intend to learn with you how to deal with that problem. But this is a global problem. This is it is not still a reality in Europe, or at least in Portugal, as it is here. But we must prepare, because in a globalized world that we are living in, it will arrive. But what I feel is that we have the tools to address new challenges as they appear. We are prepared for that, okay? And we can offer to our dependents, we can offer safer opioids, such as methadone or buprenorphine, instead of having them having fentanyl on the street. We can offer them safe injecting places. We can offer them drug checking sites where people can test the drugs before using them. So a comprehensive policy of harm reduction policies, along with treatment, prevention, reintegration, in this context of decriminalization. For me, this is our experience. We are not willing to sell our model, but we want, we are very, and I personally am very happy to have this opportunity to share with you. Up to you to decide. We are in the house where decisions are taken. Thank you.
So, thank you everyone. Thank you, Dr. Goulão, for sharing your experience. And as I said, I look forward to introducing you on the floor as a session will start today. Really great to hear the successes that you guys have had, and I look forward to continue working on drug policies in the state of Rhode Island, and hopefully providing some harm reduction, like you had said, and some treatment for many of the folks that need this, and start treating this as really as a health issue rather than a criminal issue, and maybe focus our resources on, especially our police resources, on distribution and folks that are distributing large amounts of drugs. So thank you for being here today, and thank you for all your work. Thank you very much, especially many of my colleagues that are here today to listen to this presentation, and I look forward to working with all of you on the bill that I sponsored last year.
Should we take some questions?
Yeah, absolutely. Good. So anyone have any questions for? Representative Serodino.
Thank you very much for coming to us with your expertise. I have a simple question for you. Does your program cover the archipelagos of Azores and Madeira? And a follow-up question, what part of Portugal is mostly there that we have the continent?
Thank you for your question. There's a large autonomy for the autonomous regions of Azores and Madeira. So they were not committed to develop the same model immediately upon the approval in mainland. But 1 or 2 years later they followed the same pathway, and nowadays is exactly the same. Okay. There are some fluctuations and some realities that affect the islands differently from what happens in mainland. The Azores, for instance, are in the roots of cocaine through Europe, and the use of cocaine in those islands is particularly high by comparison with what happens in mainland. But they have also the tools to deal with it. And the number of overdose deaths that I refer include the islands. Okay? So the 38 in 2017 include what happens in the islands.
Representative Dunham?
Sorry.
Oh, so who had a question? John Prince?
Hi, Doc. See, I seem like I met you in Denver a few years back at the, and I was impressed. Yes. And I was impressed with your country, how you dealing with epidemic of addiction. And so my problem is like in the 90s when crack cocaine swept the urban cities. There was nothing being done. It was forced mass incarceration, like you said, locking folks that had addiction, locking folks like myself up for many years, right? And it seemed like when opium came along, this is just my imagination, that there's a crisis. Now everybody has to be on. So did you feel that way in your country dealing with the legislatures of passing and letting folks have this medical clinics and things that you have in your country? How can it be served here in a democratic way where everybody takes advantage of it?
That is really a great question. You know, by historical reasons, the onset of problematic drug use in Portugal happened in a different way from what happened here. We lived for a long time under a very tough regime, Salazar regime. During that time, we had no problems with drugs. We had a very controlled society. But suddenly, after our democratic revolution, there was an explosion of drug use. And it happened not only among poor, the minorities, ethnic or others, but it happens through all society. And I believe that that's why we had the opportunity to develop services, responses to all the population, because it was attaining medium class, upper classes, everybody. Okay? Probably until now that was not the case in the States. Problems were in the ghetto, but nowadays those problems are attaining all the American families. That's the momentum to change. So I think you must take this wave, you must surf this wave to change things. Okay?
Thank you for your response.
Thank you.
So, Doctor, do you fund the recovery programs through universal health care, and was that a hard sell to the population to use money to do that? How do you fund recovery programs?
We have in fact a universal health system, but we developed under the General Service National de Saúde. We developed a specific set of responses to address addiction. Nowadays, we deal not only with illicit drugs, but with alcohol, with gambling, with screen dependence. So we have specific units devoted to this, with around 2,000 professionals all over the country. Okay? And this is funded through the national budget. Okay? So for the patient, for the citizen, it's free, completely free. We have a complementarity with the private and social system. That means NGOs and so that organize therapeutic communities and so on. And we have the regulatory power. So we attribute licenses to those units, provided they have multidisciplinary teams of professionals and adequate conditions. And once they get the license, they can apply for a contract with us. So when we send them patients, we pay for it. Okay? And that part of our budget comes from the profits of the state lotteries. Yeah?
That's interesting.
Yeah? So the money to fund those, that complementarity comes from the profits of lotteries.
So you found a funding source before you put the program in place?
Yeah. Yes.
I just want to ask you one question. How long is that program from beginning to end? Do you know?
We have the capacity to tailor-make the response to the client. We are dealing with a chronic relapsing disease, so people sometimes relapse. Okay, we don't give up. We are there, so they can come back. We don't drop people. Okay, come from a treatment, but next week, next month, you relapse. We are there with the street teams approaching him, inviting again. Come on, let's go. Or at least providing harm reduction responses, since safe injecting rooms to providing syringes and needles to low threshold methadone programs, whatever it's needed. Okay, you are in a good condition, let's go. You accept a therapeutic community, let's go for 1 year.
God
And
bless you.
once and twice. Whenever needed.
Thank you. What's your approach to underage youth? And has your country seen an increase in nicotine addiction with vaping products?
No, nicotine is fading, and the use of other substances, such as cannabis, for instance, which is by far the most used illicit substance in our reality, the beginning, the experimentation has been delayed for several years nowadays. People tended to initiate experimentation by 11, 12 years old, and nowadays it happens around 16. So, because on top of all this, there's a lot of preventive work, information, and so on.
The vapor stuff, the big epidemic we have in the United States, do you have that problem there too?
Not yet. It's a little bit like fentanyl. Not yet. They're not the wood. Please.
Which one? Just basically, I was wondering, since you started this, how has it saved the country overall? I mean, that you're living where you're living, the people. From an overall perspective, I'm assuming because resources were being spent in all different directions before, in all different ways. Now that you've got this implemented, have you had a chance to look back and say, you know what, now we're this much better off than what this was overall, since you're taking it from the poverty?
We look at all these policies, all this set of policies as a good investment that was made, okay? And the general population agrees on that. And now there are some talks coming from the ground, from the population, because what they feel. We have been successful.
Right.
No doubt. Drug and drug addiction was the first concern of the Portuguese people in 1997. The Poles, okay, what's your main concern? Drug and drug addiction. But I fear for my children. Nowadays it ranks 14. Okay? So it has lowered in political priorities. And it has lowered in budget and in investment, visibility. We are now claiming for, okay, don't disinvest because we can have an outbreak. This kind of policy needs a sustained investment to be successful. But general population agrees with that investment. Yeah.
Look,
Please.
the crime rate, how did it affect the crime rate?
Sorry?
The crime rate for your country?
We never had a big violent criminality related to drugs. Shootings, Hollywood scenes, we never had. But acquisitive crimes, petty crimes were very present in everyday's life. Ladies could not wear a purse, or we could not leave anything inside the car because it didn't. Nowadays, those rates of petty crimes have decreased. I cannot tell you the percentage, but it has decreased. Portugal is one of the safest places in the world nowadays. Ranks third in the world in safety.
Yes. So since 2000, how has policy, access to treatment, and stigma been impacted with alcohol dependence?
Well, you know, as I said, when the big challenge that was the heroin epidemic started to fade, instead of downsizing the services, we included other problems, okay? Other problems in the services. And the first one were the alcohol-related problems. The first reaction of people whose main problem was alcohol was a little bit, I don't want to attend the same places where drug addicts have been fallen. Then we changed the name of the service. That was Institute on Drug and Drug Addiction. Okay? Drug. Nowadays is SICA, Service for Intervention on Addictive Behaviors and Dependencies. And this is important in the representation of the people. Since we changed the name, alcoholics started to come. Okay? And then after people with problems with alcohol, gamblers, people with screen dependency, and now we have all that range of people with addictive behaviors and that seek for help coming without feeling any kind of stigma.
One more question. I just want to know, how did you get the money? How did you come to the
This is a very cheap. This is a very cheap system. People tend to ask me, did you move the budget from justice, prisons, and so on into the health side? No, we didn't. We kept the budget in prisons and in police organizations and so on. They have much better conditions to work nowadays than before. The prisons are not overcrowded as they used to be, and they can have all the kind of support. If someone is in prison for drug-related crimes, there's a lot of people in prison for drug-related crimes. Acquisitive crimes are not considered on this decriminalization. Okay? If you steal something, you can end up in prison, even if drug use or drug dependence may be a slight attendant. Okay? But nowadays, everybody in prison that wants to be treated for their addiction have the access to treatment inside prison. We even have therapeutic communities inside the prisons. Okay?
When do they start learning in school? Where does the education for the kids come from?
Since very early ages, we start to talk about substances and mostly about pleasure and sources of pleasure. Okay? Because instead of just saying, oh, drugs are dangerous, drugs kill, drugs are good. Drugs are so good that they may turn the only source of pleasure in your life. Okay? And that is the basis for our preventive work. So instead of frightening, showing skulls, they are good. But
Scientifically, don't you think that little kids have brains? They can
yes,
soak up so much more.
and during all the scholarship they must discuss, can we have universal programs of prevention in schools, where we try to develop resilience and the capacity to make informed choices in young lives.
Thank you.
So, please.
How has, sorry.
Go ahead, you can, go.
Perfect. How has the impact of medicalization of drug abuse impacted folks who've been kind of grandfathered into the prison system prior to the medicalization and treatment and destigmatization of drug use and dependence disorders?
We have, as I said, our main problem, substances, came from heroin. So it was crucial to have substitution treatment available under any circumstances, and also in prisons. So we have methadone, we have long-lasting programs in methadone since the end of the 80s. But it is possible to have the so-called drug-free programs also in prison with psychosocial support, with the intervention of psychologists, psychiatrists, social workers that work with the inmate and prepare their release.
So are there programs to rehabilitate them to society now that it's being destigmatized and medicalized, to take them out of the prison system and then treat them outside of prison doors and into society? Or is it purely to keep them into prison?
It varies and it depends, but even the judge may decide, instead of sending someone to prison, may send him to him or to a therapeutic community outside, may send it to a treatment center, and up to the professionals of the treatment center to decide pathway that must be followed by that patient. It's not the judge that determines, okay, this guy must attend, must be followed in the therapeutic community, or must be included in the methadone program. No. Health professionals do so. The judge just decides, okay, this guy, instead of going into prison, must undergo treatment.
When the program, when you decided to change this program over, did you go back and find out some of the people that were just recreational users, and were they removed from the prison, or they just stayed there, finished their time?
No, those who were convicted came to the term of their conviction. Okay? So it was not retroactive. Okay?
Yes, doctor, thank you. Yeah. I asked this question a few days ago, but I'm going to try to redo it. Thank you for the legislators that are here. You're really showing interest in this. I really, really thank you folks for being here. How do we get to change the minds or actually educate legislators? Because they're the ones that are going to be making these bills and passing these laws. What is the best way for us to get to them and to talk to them and
I know education is good, but how can we get in, really in, to talk to them and expose this?
I think the most effective way is to launch this discussion on the community and to have the real opinion of common people. Because they're people, those are the voters. And I believe that, for me to say so, I believe that politicians are very much pending from the public opinion and from the wave to be surfed. You know? I believe that, of course, working, reflecting with politicians, but with policymakers is very important. But to have kind of a bottom-up movement on the society is the most effective way.
Dr. Goulão, it is very well known the impact that the big pharmaceutical industry has had on the epidemic, perhaps more so here than in Portugal in the 90s. How do you see that as a physician when you are seeing your patients, and what has been the impact on the pharmaceutical industry of the Portugal case? If any.
Second part of the question, I think, was not, it really did not impact, because our problems, our opiate problems are not related to medicines. Okay? Really, what was really present in our reality was heroin. We have different traditions on prescribing opioids. In Europe and the States and Canada, we are completely different. Of course, we use opiates in severe pain, for control, oncologic pain, or other kind of situations like that. But I believe that perhaps because you have here the pressure of the industry, there was at least an over-prescription of opioids for relatively mild conditions. I remember being a family doctor. I used to be called to attend in hotels in the Algarve, the touristic area of Portugal, some American citizens, and I was completely amazed with the traveling pharmacies that they were taking with them, with opioids to deal with quite mild situations such as diarrhea or things like that. It's unthinkable in Europe and particularly in Portugal to have people using opioids to treat that kind of situations. So what happened, in my view, is that you have a quite important population of iatrogenic opioid dependence. So with dependence caused by medical intervention, okay? Or medicalized intervention. And when you noticed this was happening, the attempt was to close the tap. But that number of opioid dependents was already there. So if they are not offered safer opioids, such as methadone or buprenorphine, they will search dangerous opioids, such as heroin or fentanyl or whatever. And I think the killing started with that. So one of the ways to deal with it is, in my view, having safer opioids available, easily available for those who need it, instead of punishing them. Okay? So have methadone, buprenorphine available, easily accessible for all those who need opioids. I think this is a key step to stop the killing, along with naloxone, with Soil. You are doing well in that direction, I believe. So that's what I feel about the subject.
Any other questions?
So happy to have so many.
Yeah. Well, I'm happy for everyone who came out today and participated. And definitely the substance use policy education, recovery pack, all the work that you guys have been doing to help educate us on many of these important topics. And so the session's probably going to be starting pretty soon, so we can probably just wrap up. Thank you.
Thank you.